Today we are going to discuss some important aspects of gestational diabetes. The information in this presentation is based on the 2018 ACOG Practice Bulletin on gestational diabetes. Please read the Practice Bulletin, and only after you have done that, watch this presentation. After watching the presentation, you'll probably need to go back to review some of the information in the Practice Bulletin that you may not have retained during your first reading. Gestational diabetes is a relatively common complication of pregnancy. It occurs more frequently in women who have had prior gestational diabetes, are obese, older, of certain races and ethnicities listed in the Practice Bulletin, or who have conditions known to be associated with glucose intolerance, such as PCOS. It is thought to be related to concentrations of pregnancy-related hormones, including human placental lactogen, and for this reason, women pregnant with multifetal gestation, twins, triplets, etc., are also at higher risk. Women with GDM are at higher risk of gestational hypertension, preeclampsia, and cesarean delivery and its associated potential morbidities. Women with GDM also have an increased risk of developing diabetes later in life. Although exact numbers vary depending on ethnicity and rates of obesity, a general figure is that 50 to 70% of women with GDM will develop diabetes in the 20-plus years following pregnancy. For this reason, history of gestational diabetes is important for not just an OBGYN, but also for primary care providers to know about. Babies born from pregnancies complicated by GDM are at increased risk of macrosomia, neonatal hypoglycemia, hyperbilirubinemia, operative delivery, shoulder dystocia, and birth trauma. They are also, along the lines of fetal origins of adult disease, at risk for obesity, diabetes, and other metabolic complications later in life. ACOG recommends universal screening between 24 and 28 weeks using the 50-gram oral glucose challenge, commonly referred to as a glucola. If that is normal, no further testing is needed for that particular pregnancy. If the glucola is abnormal, and you can read in the Practice Bulletin about the relative advantages and disadvantages of using different cutoffs to define normal, one proceeds to a 3-hour oral GTT. Patients who have risk factors for GDM, which are outlined in box 1 of the Practice Bulletin, should be screened early, generally when they present to initiate prenatal care. If early screening is normal, it should be repeated at the standard time of 24 to 28 weeks. Please note that a high proportion of patients will meet these criteria to require early screening. Until about 15 years ago, there was no clear evidence that treatment of GDM reduced adverse outcomes. Since that time, however, there have been at least 2 large randomized studies that did show a clear benefit to treatment. Thus, we can state that treatment of gestational diabetes is an evidence-based intervention. The 2 major studies are outlined in the Practice Bulletin. Treatment reduced the incidence of large for gestational age babies, shoulder dystocia, cesarean delivery, and in both studies, hypertensive disorders of pregnancy. For treatment of GDM, diet and exercise are both important and are evidence-based. You can read some of the specific dietary recommendations in the Practice Bulletin. In clinical practice, most of us have diabetic educators and/or dietitians to do this counseling with the patient. In the former 2013 Practice Bulletin, ACOG specifically stated that when pharmacologic treatment of GDM is indicated, insulin and oral medications are equivalent in efficacy and either can be an appropriate first-line therapy. However, since 2017, ACOG states, insulin historically has been considered the standard therapy for GDM management in cases refractory to nutrition therapy and exercise, and this has continued to be reinforced by the American Diabetes Association. Essentially, current ACOG recommendations are for insulin if pharmacologic therapy is needed for GDM. They caution that healthcare providers should counsel women of the limitations and safety data when prescribing oral agents to women with GDM. ACOG does allow that metformin is a reasonable alternative choice in some cases. For instance, if the patient cannot afford or cannot safely use insulin, or if she declines insulin. Although ACOG does not state that glyburide is absolutely contraindicated, they do caution that it has not been shown to be as effective and should not generally be used. Postpartum screening at 4 to 12 weeks is recommended for all women who had GDM to identify women with either underlying type 2 diabetes or impaired glucose metabolism. Either a fasting plasma glucose or the 75-gram 2-hour oral GTT have been used for this screening. Although the fasting plasma glucose test is clearly easier to perform, the 2-hour GTT is superior because it also tests glucose tolerance. The 2-hour GTT provides both a fasting glucose value as well as the 2-hour value. This algorithm is from the ACOG Practice Bulletin. If the patient is diagnosed with impaired fasting glucose, impaired glucose tolerance, or frank diabetes, she should be referred for appropriate management. If her postpartum screening is negative, she remains at risk to develop diabetes in the future. As noted earlier in this video, her risk is as high as 70% and should thus have frequent repeat screening. The American Diabetes Association and ACOG recommend repeat testing every 1 to 3 years for women who had a pregnancy affected by GDM and had normal results of postpartum screening. Thank you for your attention. You'll probably need to go back to review some of the information in the practice bulletin that you may not have retained during your first reading. During our in-person teaching session, we'll readdress many of these points. I look forward to seeing you there.